Good afternoon, I'm Estefanía Ramos. This presentation named as Prevalence of Human Papilloma Virus infection and coinfection in patients diagnosed with oropharyngeal cancer in three American countries is framed within the Headspace project with the participation of the actors and institutions here on the screen. Today I'm presenting the preliminary results of the first group of cases of the work package 3 led by Dr. Sandra Perdomo. As you can see from the agenda, we'll be talking about oropharyngeal cancer and HPV. To start, oropharyngeal cancer develops from the squamous cells that cover the tonsil, base of the tongue, soft palate, and uvula. HPV infection have been recognized as an important risk factor that has driven an increase in the OPC incidence. More specifically, HPV now accounts for 71 and 51.8% in all of pharyngeal cancer cases in the USA and UK, respectively. Of these, from 85% to 96% are caused by HPV-16. This increase, especially for oropharyngeal cancer, due this genotype has been more than 225%. It should be noted that oropharyngeal cancer has one of the fastest growing incidences of any other type of cancer in high-income countries. In fact, according to the Global Cancer Observatory in South America, the estimated number of cases of oropharyngeal was 70,292 for 2020, and the countries with the largest contribution were Brazil, Colombia, Venezuela, and Argentina. Particularly, most research has been oriented to describe prevalence of HPV in head and neck cancers by anatomical site. In South America, according to the most recent meta-analysis, it is estimated that the prevalence of HPV in OPC and in oral cavity cancer is nearer to 24%. Yet, the above was established from the systematic review of only 38 publications. Most of the studies mainly relate the frequency of the HPV-16 genotype. As a summary, for OPC, only few studies have shown prevalence values for South American countries other than Brazil. The landscape is more deserted in terms of estimated prevalence values associated to other high or low risk genotypes, which could be playing an important role in oropharyngeal cancer. On the other hand, studies that analyze different risk factors for HPV infection, such as smoking status, alcohol consumption, and sexual habits, are limited. So, therefore, it is necessary to carry out studies that compare the data recorded for this region as well as the variation from the data from Brazil and other South American countries with respect to the rest of the world. Such effort will contribute to the knowledge of viral infection and the establishment of risk factors for oropharyngeal cancer in our population. So, the main objective of the current study is to determine the prevalence of single, multiple, high, and low risk HPV infections in patients diagnosed with oropharyngeal cancer in three South American countries. This study was carried out for a set of 159 patients diagnosed with OPC during 2011 and 2018, included in the interchange study. Currently in charge of the Headspace project. Patients were recruited for different institutions in Brazil, Colombia, and Argentina, and the process was executed in three phases. First, DNA extraction, followed by the HPV DNA testing by HPV dial flow sheet technology. Finally, as a third step, the resulting data was analyzed. To introduce you briefly in the methodology, I would like to talk about the HPV dial flow technology, which was used for screening and HPV genotyping. This tech relies on the specific amplification and hybridization of the DNA and allows the detection of 18 high-risk and 18 low-risk viral types. This technique is based on the DNA flow technology, which allows to the DNA to flow through a membrane via mechanisms that activates hybridization in a 3D porous environment. First, DNA amplification of the fragment of the L1 region of the virus and a fragment of the human beta globin gene as an internal control is performed. Here, the regions of the PCR mixture and the thermocycle conditions used in the assay are listed. Afterward, amplification are hybridated In a membrane with a specific growth for HPV genotyping, a universal genetic flux for HPV screening, and amplification and hybridization control proof. The hybridization was performed in sets of 12 using hybrid spot 12, which is a semi-automated equipment that allows HPV DNA molecules to cross the membrane and bind to the complementary proof. Then a colorimetric reaction was carried out by adding substrates that detect the alkaline phosphatase activity, creating purple precipitates. Subsequently, the chips were read in the HybridSoft platform. This schematic shows the arrangement of the proofs of the HPV chip as it can be seen. All the proofs are duplicated to ensure their reliability in the interpretation. As a result, for 159 tumor samples, 143 were executed and 60 were excluded due to DNA quality. Of the 143 analyzed, 112 were positive and 31 were negative for viral DNA. Among positive samples, 62 were infected with a single HPV type and 50 were infected by multiple types of HPV. The prevalence of HPV according to risk category classification showed that in single infection, the high risks are predominant, being only one infection with a low risk genotype. Meanwhile, the distribution of multiple infections showed the same pattern. Co-infections with two or more low-risk genotypes were not detected. Multiple infections mostly involve high-risk genotypes, but typically a single case showed HPV co-infection with a high and a low-risk viral type. The number of patients having either a single genotype or a dual infection was markedly higher than those having 3 or 4 genotypes. Regarding the HPV prevalence HPV genotypes, the HPV-16 was the most prevalent genotype within the single infection, followed by HPV 35 and 33. As for co-infection, there was a higher prevalence in patients infected with HPV-16 and HPV-35. Other less found frequent genotypes were HPV-26, 18, 31, and 66. It was not really that HPV 26, 31, 66 genotype could be only detected in co-infection. In 10 or low-risk genotypes, only 3 were detected, HPV 42 as a single infection and HPV 44 and 55 in co-infection. When we describe the genotypes combination in co-infections, our data show the HPV genotype with a high clinical relevance co-infect all the genotypes tested, being HPV 66 and 35 the most common co-infection. Other frequent co-infection genotypes were genotype 16 with 26, 16 with 31. The least frequent combinations were 16 with 33, 16 with 18, and 31 with 66. Additionally, genotypes 26, 31, and 33 were co-infected with the couple 16 and 35 after evaluating 3 or more infecting genotypes. A unique combination of high and low risk genotype was found and included the genotype 16, 44, and 55. So based on this data, we conclude that HPV is highly prevalent in oropharyngeal cases from South America and might play an important role in its development. The prevalence here was markedly higher than other studies from the same region, for example, Interchain and the Headlights study. And the most prevalent genotypes detected were high-risk HPV genotypes. Infections occurred were both single and multiple, and the prevalence and association among different high-risk genotypes mostly likely represent a synergistic interaction in oropharyngeal carcinogenesis. As a perspective, this data is being analyzed to estimate the HPV prevalence and genotype-specific prevalence values for per country. Additional studies are granted to determine possible associations between risk factor and HPV infection.